Hello everyone and welcome to another endoscopic case presentation. This case demonstrates a rare endoscopic finding which may cause confusion and misdiagnosis. A 70-year-old man was found to have iron deficiency anemia with a hemoglobin of 104 grams per litre and a ferritin of 14. He attended for an urgent upper GI endoscopy and colonoscopy. The colonoscopy to the cecum found two small 5mm polyps which were resected and a single small caecal angiodysplasia. The polyps turned out to be tubular adenoma with low-grade dysplasia. The OGD showed a strange appearance in the duodenum with what looked like a fold or pedunculated polyp in the second part of the duodenum, as shown in this photograph. The mucosa looked abnormal at the base of the fold, and biopsies were taken showing focal alveolar gastric metaplasia. A CT scan was also requested, which showed thickening of the third part of the duodenum, but no other sinister features. The patient has now been referred for another OGD with a view to reassessing the duodenal polyp and performing polypectomy. We join the endoscopy in the second part of the duodenum. There is an angiodysplasia visible at the apex of that bulge at 12 o'clock. We slowly pull the scope back into the first part of the duodenum and then into the antrum. Re-entering the duodenum, we can see a strange strip of mucosa at 5 o'clock beginning at the D1-D2 junction. The surface pattern of this strip looks different to the surrounding mucosa and it is coarser. The strip is narrow but several centimeters in length. As we traverse the D1-D2 junction and enter the second part of the duodenum, again we can see a polypoid structure with what appears to be a long stalk. This is likely to be the polyp encountered at the previous endoscopy. However, on closer inspection, there appears to be an orifice at the base of the stalk, and I'm able to pass the scope through the orifice and enter a blind-ending pouch. So this is not a polyp at all, but a diverticulum. However, unlike the true duodenal diverticula that we commonly see at OGD and ERCP, which are extraluminal, this diverticulum is entirely intraluminal. These intraluminal duodenal diverticula are believed to arise from a congenital duodenal web that progressively elongates as a result of normal duodenal peristalsis. It is thought to be part of a spectrum of duodenal recanalization disorders, including duodenal atresia and stenosis. Since there is no obstructive symptoms, the intraluminal duodenal diverticulum does not require treatment. We will bring the patient back another day to treat the angiodysplasia with argon plasma coagulation. The angiodysplasia is likely to be the cause of the iron deficiency anemia. If we now look at the CT scan, which was performed after the first endoscopy, we can see the intraluminal duodenal diverticulum with the benefit of hindsight. On these coronal sections, the intraluminal duodenal diverticulum looks like a windsock, and its apex protrudes into the third part of the duodenum with the base at the D1-D2 junction. In the transverse sections, two lumen can be seen, and I've shown the diverticulum with an arrow. The other lumen is the normal duodenum. There is more information about intraluminal duodenal diverticula in the text that accompanies this video. I hope you enjoyed this presentation. See you in the next one. Bye for now.